So to start our session, no, we haven't started, we're just starting. So to start our session, I'll share my screen. You have the option just to interrupt if there is any point unclear, yeah? Can you all see my screen? Hosam, can you see my screen?
Yeah, it's clear.
Perfect, okay. Good. So let us start. So basically this will be our first lecture about foot and ankle review. This will be a course of around 8 to 10 sessions or lectures. We'll go together through what you will be asked in FRCS Bar A and Bar B, mainly directly Part A, the main questions, and definitely this will be the base you'll use in Part B in practice and in Viva. My name is Mohammed Hashim, and I'm a consultant foot and ankle surgeon at Wixon Park Hospital, Family Health NHS Trust in Northwest London. So today, hopefully, we'll speak about anatomy, biomechanics, and gait. Anatomy here, I mean clinical anatomy. I'm not an anatomist, so I'll not go into academic part of it. I'll go to the clinical. What in the anatomy makes difference for you as a clinician? So this is my hospital. This is our elective hub, Heatherwood Hospital in Ascot, and it's a state-of-art new hospital with very good facilities. So this is two channels which will help you. So all our sessions here will go on both of them. This is under mainly OrthoBima official channel. I'll be sharing over my educational channel because it has a bit more subscribers. So do subscribe to both of them and you will get every new. Okay, so if we speak about the ankle, basically, as you see, ankle is formed mainly of two joints. Okay, so the ankle joint and the syndesmosis. Ankle joint, which is a synovial modified hinge, and the syndesmosis, which is basically a fibrous joint. Though the syndesmosis is a fibrous joint, it is still move, and you will see now how it does move. So basically, the tibia come and flare into the quadrilateral surface, which we call the plafond, and articulate with the talus to form the ankle. Then the fibula come and sit inside the notch, the fibular notch in the tibia, and make what we call the incisura, and make it the syndesmosis and make the articulation between the tibia and fibula. The points which is in bold, you need to understand that the distal tip of the medial malleolus, the lateral malleolus is beyond the medial malleolus, so the ankle is not at the same level. So basically the lateral malleolus is lower than the medial malleolus, and this has a very important effect on the ankle because basically the lateral buttress of the ankle is more stronger than the medial buttress of the ankle. That's why we agree on a Weber E fracture to be a stable fracture treated non-operatively, but we cannot accept that for a medial malleolar fracture. So if you have a look at the joint, so the ankle compared to the knee, the ankle is a smaller joint. So all the surface of the ankle is 350 mm, while the knee is 1,100 mm. And the articular surface in the ankle, the articular cartilage itself, the layer is more thinner than the knee. But still, there is a very common question why the ankle doesn't get arthritis like the knee. So the knee arthritis is much more prevalent than the ankle arthritis. A big question. If the articular surface is thinner, if the surface area is smaller, so getting more loading, why the ankle is not like the knee in arthritis, and still the knee is getting arthritis much commoner than the ankle? And the answer basically that the ankle is a very congruent joint. So if you see the shape here, the ankle, as you see, is a whole box with very good articulation, very good configuration, conformation between the surfaces. And this is what makes no point loading in the ankle, which is not the case in the knee. In your knee, there is a point loading. So basically, when you put load in your knee, there is at certain point an tibio-femoral relation with a point loading at certain point, which makes the ruling after that with straightening and bending. So basically, the ankle is very conform. So the conformation of the surfaces is very good. So the surfaces are very well co-opted. So there is no point loading. The ankle is loaded as a whole joint with the whole surface. So no point loading. So the risk of getting arthritis is much lesser than the knee, because even the knee is bigger. But at certain point of loading, the knee will be loading at one point. So you load at one point medially, you load at one point laterally. You start with medial because the medial femoral condyle is much lower than the lateral. And then with moving the knee in any direction, you still change the point of loading between the femur and the tibia according to the rolling mechanism, but will end by your knee in all positions having a point loading. And that's why the knee is more commoner to get arthritis. And that's why the knee, the arthritis in the knee is mostly medial. That's why the medial compartment arthritis of the knee is the commonest area in your body to get arthritis, which doesn't happen in the ankle. But on the other hand, the ankle is very prone to get arthritis post-traumatic. Why post-traumatic? Because basically you change this conformation. So the idea of the conformation that the ankle is co-opted in this position, so it's fully smooth surface, conform surface. Once you change this conformation by any degree, you get arthritis. That's why the post-traumatic arthritis ankle is higher than any other joint in the body. And as you see, only 1 millimeter Taylor shift in your ankle will decrease the contact area by 42%, and it changed the whole conformation, lost the ankle, the most important point, make it less prone to getting arthritis, and that's why your ankle will get very commonly to get post-traumatic arthritis. And that's why reduction of the ankle, fixation of the ankle has to be perfect. You can accept tibial plateau with not perfect reduction. You definitely aim to anatomical reduction, perfect reduction, but if you don't get it in the knee, your patient will get arthritis on a long run. But in the ankle, if you don't get the ankle perfectly reduced with even 1 millimeter, he will get post-traumatic arthritis very quickly. I hope this point is very clear. If we go to the anatomy of the plafond itself, so you need to understand that the plafond is multiple columns: anterior column, medial column, posterior column, and definitely the fibula plays the lateral column. We'll concentrate on the plafond, and can you see the plafond? You have the medial malleolar fragment here. You have the Volkmann's fragment posteriorly and the chapped fragment anteriorly. And compared to the chapped fragment in the fibula is the Wagstaff fragment. So when you have a fracture like that, you have to identify the fragments. This is the commonest configuration, what we call Mercedes configuration. The commonest configuration you will have in a plafond fracture, and this is what gives you is a way to identify and the way to communicate. When you look at an X-ray of the ankle, as we agreed, the ankle is two joints: the tibio-talar joint and the syndesmosis. And when you look at the syndesmosis, you need to understand that the syndesmosis is incisura fibularis, and the fibula is sitting inside it, and between them there is a clear space, and there is a bit of overlap between the tibia and the fibula. And the judgment here is based on 1 centimeter from the joint line, and you need this space, which is a clear space, less than 6 mm. If 6 mm more, this means syndesmotic injury, and you need an overlap between the tibia and fibula at least 1 mm or more. If these numbers are disturbed on a proper Mort's view, so you have a syndesmotic injury. Once, as we agreed, the ankle is a fully conformed surface joint. So any disturbance in this relation will end by disturbance in the clear spaces. You have medial clear space, you have superior clear space, you have lateral clear space. They should be all normal and less than 4 mm. And this relation between the syndesmosis, tibia, and fibula, and between the ankle and the tibia and fibula should be all uniform. And uniform for you. So if you compare it to the other side, it should be the same. Any disturbance in one of these figures will disturb the others. And if we start to look to the ankle as a ligamentous structure, so regarding the syndesmosis, the first joint, the syndesmosis is maintained by 3 ligaments. So the anterior tibiofibular ligament, inferior tibiofibular ligament, or AITFL, and posterior inferior tibiofibular ligament, and the interosseous ligament and the interosseous membrane. So you have 4 ligaments controlling the movement of your syndesmosis: anterior inferior tibiofibular, and posterior inferior tibiofibular, interosseous ligament, and interosseous membrane. And strongly, the most strong of them is the anterior inferior tibiofibular. But the most commonly injured one is the posterior. Why? So why firstly the anterior inferior tibiofibular is the strongest? Because basically because of the relation we said about the lateral malleolus is lower than the medial malleolus, your ankle tends to extend and rotate. And you basically, if you don't have enough movement in your ankle, you tend to extend and rotate your ankle to declare your ankle from the ground. So the main moment on the ankle is an external rotation moment. An external rotation moment ends by opening the syndesmosis from anterior. That's why your anterior inferior tibiofibular ligament is the strongest. Your problem is anterior inferior tibiofibular ligament is injured. Once the anterior inferior tibiofibular injured is a ring, and once the anterior inferior tibiofibular ligament is injured, you put stress on the interosseous ligament, and interosseous ligament is easy to be injured, and this is the time when the posterior inferior tibiofibular comes in on board. And because it is very strong, it's commonest for you to see a syndesmotic injury or a fracture from the back, from the Volkmann's fragment, or posterolateral fracture. So you commonly see one of two options, either a syndesmotic injury with no fracture. This is mostly because of injury to the anterior inferior tibiofibular, and or the other side, you will have a avulsion from the back, not an syndesmotic injury from the back. And both of them are syndesmotic injury by definition. Basically, this is the ankle. This is a syndesmosis between the tibia and fibula. The anterior inferior tibiofibular is strong because your ankle tend to extend and rotate. So this should be stronger. Otherwise, your ankle will be always spraining. And if you have an injury to this ligament, you have a high ankle sprain or a syndesmotic injury. Then you have the interosseous, which is easily injured because it's more or less dynamic. Then you have the posterior inferior tibiofibular, which is maintaining the relation in the back. And this ligament, because it's away from anything, if you have to do something for this, you will fracture the bone rather than injuring the ligament. Your syndesmosis normally moves. So the fibula inside the incisura is not fixed. It is a fibrous joint, yes, because there is no synovium, there is no articular surface. It's a fibrous joint type, but it still moves. It moves in external rotation and it moves backward. So the fibula moves backward to the tibia and it moves in external rotation, moves backward to the tibia when you dorsiflex and external rotate inside the incisura if you external rotate your foot. And this movement is not a minimal movement. It moves about 5 to 7 degrees in external rotation and about 3 to 4 degrees millimeters front and back. And because of this movement, there is a lot of discussions now about the syndesmotic fixation. Because when we put a screw, we fix this joint, we don't allow this joint to move. And without moving it, we disturb the mechanics of the ankle. Though it is still the common practice to put a syndesmotic screw, but this is not anatomical, because anatomically, this fibrous joint does move. The fibula moves 5 to 7 degrees external rotation, and it moves up to the back about 3 to 4 mm. And when you fix that, you disturb this movement, you don't allow it anymore, and this is disturbed the whole mechanics of your ankle. That's why the tightrope came in place, and now the tightrope use is going more and more. But the problem with the tightrope is this is very flexible, and it depends on your tension when you put the tightrope to do the job. So it has a lot of human errors. So, and that is why it's very common for you to see after everything heals a broken screw, a broken syndesmotic screw. And the broken syndesmotic screw, because you are stopping a joint from movement, and when this joint starts to move again, it will break the screw. And that's why you have to warn your patient that the syndesmotic screw will be broken at some point, and you need to get it removed or not according to your school. But when we speak about the syndesmosis, you need to understand we have 4 ligaments: anterior inferior tibiofibular, posterior inferior tibiofibular, interosseous, and interosseous membrane between the tibia and the fibula along their lengths. Strongest is the anterior because your normal moment on the ankle is external rotation. Posterior is the less to be injured, and when it has an injury, it always be a bony avulsion rather than a ligamentous avulsion. And that's why it's common to see a posterolateral malleolar fracture or posterior malleolar fracture. The syndesmotic joint is not a fibrous joint. It's basically, as we agreed, it has some movement, 5 to 7 degrees external rotation of the fibula inside the incisura, and posterior displacement about 3 to 4 mm. And when you fix this with a screw, you disturb the ankle mechanics. Though you give a chance for the syndesmotic ligaments to heal, you disturb the ankle mechanics, and that's why it's not an anatomical way of fixation. If we come to the second important ligament of the ankle, which is the deltoid ligament, which is the medial collateral ligament of the ankle, if you say. So the MCL of the ankle is a deltoid. Very strong, thick ligament. Has a superficial part and deep part. Superficial part is 3 bands, as you can see. So one from the tibia to the talus, one from the tibia to the navicular, and one from the tibia to the calcaneum. So tibio-navicular, tibio-talar, and tibio-calcaneal. And if you look carefully, you understand that the superficial part of the deltoid passes by 2 joints, the ankle joint and the subtalar joint. And that's why when the foot position gets abnormal, this deltoid is under a lot of stress. And when it's under a lot of stress and start to fail, this takes you to type 4, like pes planus, if we speak about pes planus. And on the other hand, this deltoid ligament is less commonly to injure than the lateral ligament, because basically the normal position of your ankle is to be in varus. So the normal you have 5 degrees. The normal you have 5 degrees of heel varus. You have arched foot, and that's why all your stress is also on the lateral side, not on the medial side. So actually, in the normal ankle, normal anatomically oriented ankle and foot, your ankle is in a bit heel is in a bit varus, about 5 degrees. And you standing on bit of arch. That's why the stress is more on the lateral more than the medial. So, and when you start to walk, the deltoid ligament plays a very important role in coordination of the movement between the ankle and the subtalar. So basically, when you walk and the deltoid passing by two joints, this makes some sort of relation between the movement of your ankle and your subtalar joint, and we'll come in details to this point. So you need to understand deltoid is a very strong ligament. It's controlling the medial side of the ankle. It has a superficial and deep part. The superficial part is tibio-navicular, tibio-talar, and tibio-calcaneal. It passes by 2 joints, the ankle and the subtalar. While the deep part of the deltoid is actually thickening of the capsule. And it has 2 parts only, as you see. Super deep anterior and deep posterior tibio-talar. So it's passed by only 1 joint, which is the ankle joint, and it's actually a thickening of the capsule of the ankle on the medial side. So when we come again to this point and explain the movement between the ankle and subtalar, we will understand why all of the deltoid is missed as a missed injury, why we have a lot of discussion about what we call deltoid spring ligament complex, because it's not acting alone. There is another ligament which is acting in the medial side of the foot, which is the spring ligament. So the deltoid ligament is very important. You need to understand this. You need to appreciate the parts of the deltoid ligament and to understand this configuration, especially the calcaneal one, if you see. So this is a supporting band, and you don't care about the numbers, about where is the center, where is it from the center of the movement, but the most important, you need to understand this is passed by 2, the superficial passed by 2 joints, and the deep passed by 1 joint. If you come to the lateral side, so as you see, so as we agreed, if you stand on your ankle, so normally what's happened, your ankle tend to go in. So you standing normally if you stand only static, about 5 degrees valgus, with any movement you do, your ankle invert into varus because of the tibialis posterior act. So always the tension while you are moving is on the lateral side. Someone of you will ask me a question. So we normally, if we examine the ankle and foot, we see the patient standing in a bit of valgus. Yes, statically. But this is not your position. When you're standing on 5 degrees heel valgus. But actually, with any movement you do, the tip will hold your ankle from valgus to varus. So the most of your dynamic position of the ankle is in heel varus. That's why the stress on your lateral ligaments of the ankle is more than the medial ligament. That is why commonly the lateral ligaments get injured, and you hear about lateral ligament reconstruction. You don't hear commonly about deltoid ligament reconstruction because the deltoid is not under constant tension when you walk or when you dynamically move. If you can come to the lateral structures, you have the anteriotibial ATFL, and you have the calcaneofibular. ATFL has two bands, superior and inferior band, and you have the calcaneofibular, and you have the posterior tibiotalar ligament. So anterior tibiotalar ligament with two bands, posterior tibiotalar and calcaneofibular. I'm sorry, I forgot to tell you one thing. The superficial band of the deltoid controls mainly the valgus movement. So exactly like the superficial MCL does. And the deep part controls mainly the external rotation. So if you want to stress the superficial deltoid, you put the foot or the heel into valgus, and if the ankle into valgus, and if you want to stress the deep deltoid, you put the ankle into external rotation. So this is care about the varus valgus movement, and the deep part cares about the rotation movement. If we come here, we have the ATFL, VTFL, and the CFL. So anterior talofibular, sorry, posterior talofibular, and calcaneofibular. The strongest of them is the posterior talofibular, but actually the one under a lot of stress is the anterior talofibular. Why? Because again, ignore when you're standing. When you start to walk, the first thing your foot does is to go in plantar flexion, and once it goes in plantar flexion, this puts stress while you stress on the lateral side. This is stress the ATFL. حضرتك ماشي وحضرتك واقف، your heel is in valgus. اول ما بتبدا تمشي تيب بوست بتسحب لك الهيل دي انتو فارس، تحط لك ستريس on the lateral side، وانت ماشي اول موفمنت بتعملها هيل سترايك، بعدين بعد الهيل سترايك بتبلانتر فليكس. بلانتر فليكشن with varus equal stress over ATFL. And when it stress the ATFL, this is the time when you get a lateral ankle sprain. Because ATFL is a weak ligament, easily to get sprained, and it is under tension when you're putting the heel into valgus, into varus with plantar flexion. The anterior talofibular, as you see, goes from the lateral malleus or the fibula to the talus. Two calicles, as you see, superior and inferior. Calcaneofibular, and this is an intra-articular. The ATFL is a thickening from the capsule. The CFL is an extra-articular one. CFL is very strong, and it does act in neutral dorsiflexion, not a dorsi or plantar, in just in neutral position, and if you do a varus inversion. So if we go to how we assess the injury to the ligaments, you assess the injury to the ATFL by putting the foot into plantar flexion, and you just do anterior drawer. And the CFL, you test the CFL when you put the foot in neutral, and you start doing a varus inversion. And you assess the TFL when you put the foot into dorsiflexion and do an anterior drawer. So basically, the ATFL and BTFL, you stress in anterior drawer, one in plantar flexion, which is the anterior TFL, or ATFL, the anterior talofibular, and one in dorsiflexion, which is the posterior talofibular. But the calcaneofibular, you put the foot in neutral and you stress it in varus inversion. When you reconstruct these ligaments, you need to understand that the line of action of the ligament is very, very important. If you see the anterior talofibular, it doesn't relate to the articular cartilage itself. So it goes underneath the articular cartilage, just at the level of the lateral process of the talus. And reconstruction should be in this place, otherwise it will impinge on the ankle. This is another very important anatomical point. Coming to the muscles and the structures around the ankle, you don't need this picture. You remember it from Tom has a nice dog, big and dog. So you have from the front tip and the extensor hallucis, then nice nerve, which will be the deep peroneal nerve, then a very nice so vein nerve, then big, which is dog, which is the flexor extensor digitorum, then P, which is the peroneus tertius. To remember it, the reverse in the back. So anterior you have tip and then extensor hallucis. In the back you have tip and then flexor digitorum. In the front you have tip and extensor hallucis. In the back you have tip post and flexor digitorum. Then carry on the normal as you all remember. Remember it the way you need to remember. From this picture, I need you to recognize that the FHL is muscular to a very low level. So up to the level, up to about 1 to 2 centimeter above the ankle is still muscular, and the tendon start after that. So that's why you see it in this cross section or as a muscular. It's not as a tendon, while the others are a tendon. So flexor digitorum will be a tendon, tip post at this level will be a tendon. On the other side, on the other hand, your tip ant and extensor tip ant will be a tendon, and the extensor hallucis it become to be a tendon like in the lower leg. So remember that the flexor hallucis is muscular to a very low level than you imagine. If we come to the tendons, and I need you to understand, we will speak about 4 important tendons around the ankle. I need you to understand them. The most important is a tip post. And if you understand the tip post function, you will know how the tip post play a very important role in your life. So tip post basically allow you. So tip post basically, I'll not speak about the origin insertion, but it's inserted in all the tarsal and metatarsal bases except the first metatarsal. And this is important because basically the tip post plays a very important role in maintaining your medial longitudinal arch, very important in keeping your normal position of the ankle, hind foot, and the midfoot. So without the tip post, you will be flat, and without the tip post, all the mechanics of your ankle, subtalar, and midfoot will change. Without the tip post, you will be having a big problem. So walking, for you to walk, if you compare on the right side, how much loss, look at this graph and this graph, and see with a normal tip post how the situation in different activities, and here comparison between the normal tip post and a tip post deficiency or a flat foot. As you see, your tip post plays a very important role in moving. So at this level of heel strike, then you put a flat foot, then now you're loading flat foot, and then before you do a 2-off, that is very, very important for the tip post to put in action, so she can raise your arch, she can change the planes of your midfoot or shoulder joint, and this is when you make your foot as a rigid lever. Other than this, your foot will be break at this stage. That's why you see here, in a normal tip post, it fires at this level to allow you to push off by this foot, because it makes your foot as a rigid arm, because it locks your midfoot or shoulder joint by different planes, changing the planes of your midfoot joints. Let me go to this, then I'll come back. But this is very important. Midfoot. Yeah. So if you look in this picture, normally this is the shoulder joint or midfoot joint. This is the talonavicular. This is the calcaneocuboid. The normal picture when you are flat is 2 joints are at the same plane. Tip post, when you need to push off by your foot, it just pull on the navicular and this part of the midfoot. So it changes the plane of the talonavicular to the plane of the calcaneocuboid. And when they are in different plane, they lock the midfoot, so your foot become a rigid lever. So this you can push off with. Without the tip post doing this, your joints, the shoulder joints, will maintain on the same plane, and this will make your foot easily collapsing. And that's why you have a midfoot break, and that's why the flat foot people find the difficulty to walk and get very exhausted after very short walks. I'm sorry, but this I have to explain in Arabic. I know it will be difficult. بص حضراتكم ببساطة، تيب بوست بيشتغل بإنه بيشد على، هو ماسك في كل التارسلز، كل الميد فوت ما عدا الفيرست ميتاتارسل، وبالتالي بيعمل ايه؟ بيرفع الميد ارش. على ما بيرفع الميد ارش بيحرك النافيكولار والكيوبويد لفوق، وبالتالي بيغير البلين بتاع التيلونافيكولار جوينت عن البلين بتاع الكالكينيوكيوبويد جوينت، وبالتالي عشان البلينز الاثنين مختلفه الفوت ما عادتش ينفع تتحرك من النص، الفوت بقت ريجيد، وده اللي بيسمح لحضرتك في المرحله دي تعمل بوش اوف. وحضرتك ماشي عملت هيل سترايك، رجلك نزلت على الارض بلودنج، بقت فلات، وهي فلات كده اللي بيحصل انه التيلونافيكولار in the same plane of the calcaneocuboid، وبالتالي your foot is supple، وبالتالي بتقدر تاكوموديت الجراوند. عشان ليه تاكوموديت الجراوند؟ سبحان الله، لانك لو دوست على اي حاجه والتو جوينتس دول مش في السيم بلين وسابل مش هتقدر تدوس، هتبقى كانك بالظبط دايس على مسمار ولا حاجه. لكن انت رغم ان احيانا الجراوند ما تبقاش يونيفورم، ما تبقاش سموث، your foot can adapt the ground because the talonavicular and the calcaneocuboid are in the same plane, so the foot is supple. العكس انت محتاجه وانت بتعمل المرحله دي اللي هي البوش اوف، عشان حضرتك تبوش من الفيرست ام تي بي جوينت لازم الفوت دي تبقى ريجيد. عشان الفوت دي ما تتكسرش في النص او يحصل ميد فوت بريك، لازم اللي يحصل انه التيلونافيكولار جوينت يبقى في بلين مختلف عن الكالكينيوكيبويد جوينت، واللي بيعمل الاكشن ده هي التيب بوست. من غير التيب بوست حضرتك وانت ماشي هيحصل من غير ما تحس ميد فوت بريك في النص، وده يخليك تمشي مسافات اقل واللي يبقى مؤلم جدا مع المشي. وعشان كده لو شفت واحد فلات فوت ماشي بيمشي زي البطه بيعمل كده. ليه بيعمل كده؟ لانه ما عندوش القدره على انه يفليكس، ما عندوش ارش، وبالتالي ما عندوش ريجيد ليفر مع البوش اوف، وبالتالي ما بيقدرش لانه التيب بوست بتاعته مش شغاله، فما بتعملوش الاكشن ان هو يخلي التيلو نافيكولار على ديفرنت ليفل من الكالكينيو كيبويد. At the same time المشكله الاساسيه في التيب بوست ده زي ما حضراتكم شايفين اللاين اوف اكشن بتاعه هو ماشي كده وبعدين بيتيرن 90 ديجريز ورا الميديان مال. الحته دي بتخليها زي ما حضراتكم شايفين في الرسمه اللي تحت ووتر شيد، الفاسكولاريتي بتاعتها قليله، easy to degenerate، وعشان كده is very common to have a tip post deficiency، وعشان كده الفلات فوت is a very common condition. ليه common condition؟ لانه التندون اللي بيمنعه has a problem عند اللاترال malleolus ورا lateral malleolus with a watershed area which makes the tendon weaker at this point, easy to degenerate. and مع الاكشن الكتير خصوصا الناس الاوبيز، خصوصا الناس اللي ما عندهاش اكسرسايز كفايه، خصوصا الناس اللي عندها بروبلمز، التندون is easy to degenerate، وعشان كده tip post deficiencies are common. That's why the obese people, which is put a lot of stress on the tip post, especially with this line of action, is easily for the tip post to degenerate at this and have a problem. حسام انا مش متابع، في حاجه في الكومنتس ولا الناس فاهمه لحد ما انا ماشي كده؟
لا تمام يا باشا، هو لحد دلوقتي مفيش اسئله، تمام الدنيا ماشيه تمام.
اي حد الشباب يعني have a problem بس يعني يبلغ بس حسام وانا او ستوب. تمام. اتمنى الحته بتاع اهميه التيب بوست تبقى يعني تبقى سهله. بعد التيب بوست we have the tip end. التيب end بيشتغل mainly inverter. عشان بس ما قبل ما انسى، التيب بوست طبعا الاكشن بتاعه is a plantar flexor inverter and does a midfoot adduction. ركز قوي because we will need this in a minute. plantar flexion لانه جاي من from behind the lateral malleolus, varus or inversion, and adduction, and this movement is called supination. Keep this in mind in the background. So the tip post is the strongest inverter, inverts the hind foot, plantar flexes the ankle, and does a midfoot adduction. Tip end is an ankle extensor, and forefoot again midfoot hind foot inverter and a midfoot adductor. Okay. tip post بس محتاج حضرتك تفتكر انه it wraps around النافيكولر وبتمسك في الاندر سيرفيس بتاع النافيكولر and the cuneiform, mainly the cuneiform. وبالتالي التيب اند بتشتغل when you put the foot into dorsiflexion. If you want to test the tip end and the tip post, basically with the tip post you need to put the foot into plantar flexion, and when you put the foot into plantar flexion, what you does you relax the tip post, and then the tip end is into action, and the other way around. If you want to test the tip post, put the ankle into into dorsiflexion, so you relax the tip end, and then the tip post will be into action. Then, if I want to test, both of them are inverters, but tip end goes into action in plantar flexion, tip post goes into action into dorsiflexion. Basically, you relax the muscle. So لو عملت حركة dorsiflexion, you will shorten the tip end and put the tip post under tension. Then you can test, and the other way around. كمان حضرتك you need to remember tip end doesn't degenerate. It's very 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 rare to have a tip end degenerative rupture, but you can have a tip end laceration. Very common لما تسمع عن عيان has a tip end degenerative rupture. This means that this patient has some sort of collagen disease, some sort of rheumatological disease. It's not normal for the tip end to degenerate and rupture. which is very common for a HL. So laceration, yes, but degeneration, no. Then on the other side, we have the brennii, which is acting to counteract the tip ant and tip post. They are mainly everters. We have the tibialis, the peroneus longus, and the peroneus brevis, and you can easily spot that the peroneus brevis is going in front of the peroneus longus and medial to it. The peroneus longus is going outward and lateral to it. And you remember when you open them, if you open them before, the peroneus longus is always muscular to a lower level. So to differentiate them surgically, you will find that the peroneus longus is longer than the peroneus brevis. Peroneus longus, peroneus brevis firstly goes from behind the lateral malleolus, but above the peroneal tubercle in the calcaneum and attached to the base of fifths. The main job of it is as an inverter. Everter. So the main job it does, it just evert the foot. And the peroneus longus, it comes from the back. It's more muscular to the end. It goes from outer side or lateral side and behind the tip, the peroneus brevis, and it goes underneath the peroneal tubercle in the calcaneum, goes in the groove in the cuboid, and go to insert in the medial cuneiform and base of first metatarsal. Both of them are everters, but remember, the peroneus brevis, when you put the foot into, again like the tip ant and tip post, when you put the foot into plantar flexion, you basically shorten the peroneus longus, and this when you put the peroneus brevis into action. So if you want to test for the brennii, to test for the peroneus brevis, you need to put the ankle into plantar flexion and ask the patient to evert. If you want to test for the peroneus longus, either it's so difficult for you to test the plantar flexion of first ray. The easiest is to put the foot into dorsiflexion and ask the patient to evert. This when you put the peroneus longus into action. peroneus brevis mainly من الوصف اللي قلته لحضرتك ده peroneus brevis mainly بتكاونتراكت اي ريسبونس بتكاونتراكت التيب انت وبالتالي there is a relation between the tip and the peroneus brevis والريليشن دي لما بتبقى disturbed العيان ده بيدخل في كيفس والعكس بالنسبه للبرينيس لونجس انتي بوست. فلو حضرتك مركز معايا هتاخد بالك ان زي ما قلنا انه لما تحب تست التيب انت او البرينيس بريفيس بتحط الفوت انتو دورسيفليكشن عشان تريلاكس ديم اند انا اسف تحب تست البرينيس لونجس او التيبياليس بوستيرور بتحط الفوت انتو دورسيفليكشن and ask the patient to invert فتشوف التيب بوست او يفيرت فتشوف البرينيس بريفيس البرينيس لونجس والعكس صحيح. ليه؟ لانه افتكر انه التيب انت بتبقى countered by the peroneus brevis والتيب بوست بتبقى countered by the peroneus longus. tip ant is countered by peroneus brevis and tip post is countered by peroneus longus. وزي ما قلنا ببساطة to remember it the way you examine them. Both tip ant and post are inverters. Both peroneus brevis and peroneus longus are everters. But to test them, you need to relax one muscle and put the other into action. If you dorsiflex, you relax the tip ant and the peroneus brevis, and you put the peroneus longus into action. And when you plantar flex, you put the tip post and peroneus longus, relax it, and you put tip ant and peroneus brevis into action. So basically, dorsiflexion and invert is testing the tip post and the peroneus brevis, and the other way around. Remember, peroneus brevis is countering the tip ant and peroneus longus is countering the tip post. وزي ما قلنا تاني you put in dorsiflexion you relax the tip ant and peroneus brevis so you're testing the peroneus longus and tip post and you put in the plantar flexion you relax the tip post and the peroneus longus so you'll be testing for tip ant and peroneus brevis. حسام دي واضحة ولا حد عنده أي كومنت ولا ناس نامت؟
هو مفيش كومنتات بس انا مش انا مش عارف يعني ممكن لو حضرتك تعيدها تاني معلش.
طيب عشان your ankle to be stable ويبقى dynamically stable محتاج انه الايفرترز تبقى in equilibrium with the inverters. عندك two main inverters which is the tip ant and tip post. عندك two main everters which is the peroneus longus and peroneus brevis. The tip ant is countered by the peroneus brevis. التيب بوست is countered by the peroneus longus. وبال حضرتك ده ملوش علاقه بالميكانيزم في الشاركوت ماريتوس او ازاي بتحصل بعد كده الديستربنس في الانكل، بس دي الريليشنز النورمال. يعني لما هنيجي للكيفس هقول لحضرتك انه التيب بوست is taking action over the peroneus brevis and the tib ant انا اسف البرينيس longus taking action over the tib ant. ignore this. خلينا دلوقتي في النورمال physiological situation. normal physiological situation التيب انت جاي من قدام الانكل، التيب بوست جاي من ورا الانكل، البرينيس بريفيس جاي من فوق البرينيال تيوبركل في الكالكينيوم، البرينيس لونجس جاي من تحت البرينيال تيوبركل في الكالكينيوم. البرينيس الانكل وهو في دورسي فليكشن، التيب انت والبرينيس بريفيس ريلاكسد شورتند، فما ينفعش التست بالتست مين؟ بالتست التيب بوست اللي هي اندر تنشن والبرينيس لونجس اللي هي اندر تنشن. لو حطيت الانكل في بلانتر فليكشن فانت كده ريلاكسد التيب بوست وريلاكسد البرينيس لونجس، وبالتالي تقدر تتست فور ذا تيب انت اند فور برينيس بريفيس. وبالتالي ريمبر انه الاثنين اللي بالانسنج تيب انت ويز برينيس بريفيس، تيب بوست ويز برينيس لونجس. واضحه حسام؟
تمام يا باشا، تمام.
واضحه مش واضحه ممكن انا تاني؟
لا تمام. والكومنت كلير. تمام.
كومنتات ايه؟
لا تمام، الكومنت تمام.
كومنت تمام بذمتك؟
اتس كلير ثانكس. يا
جود. اوكي. لما نيجي ل ده شكل زي ما قلت لحضرتك، ده الفيبرال تيوبركل او البرنيال تيوبركل بنسميه. فوق البرنيال تيوبركل البرنيس بريفيس، تحت البرنيال تيوبركل البرنيس لونجس. معلش هرجع الحته دي. طبعا برنيس لونجس هذا very important rule في انها تمنتين الارش بتاع حضرتك. طب ازاي؟ لانها ببساطه ماسكه في البيز of the first metatarsal and the medial cuneiform، وبالتالي it bolts the whole first ray into plantar flexion، وبالتالي it adds to the creation of the arch. تمام؟ وعشان كده زي ما قلت لحضرتك هي بتقع في نفس الكاتيجوري بالكاونتر اكت مع التيب بوست. او انا اسف مش بالكاونتر اكت، بتقع مع الكاتيجوري في نفس الكاتيجوري مع التيب بوست. فالبرنيس لونجس it acts by bluntly flexing the first ray because it attached to the base of first metatarsal and medial cuneiform, and it has a very important role in this. But this role we can ignore because we still have the tip post acting if the tip post is acting. زي ما حضرتك شايف زي ما قلنا كده الاميننس البرنيس بريفيس is above البرنيس لونجس is underneath. بعد كده البرنيس لونجس goes through the cuboid groove and go to attach there. في البرنيس بريفيس لها اتاتشمنت اسمها الديجيتي كوانتي، دونت كير اباوت، بس ممكن تسمعها في الامتحان. فريمبر ذات the perineal digiti quanti is part from the Bernier brevis. Your nice Achilles. So the Achilles, as we understand, is the strongest ligament in the body. Achilles, he gets all your weight, and he counteracts for the whole body not to drop in the front. So Achilles in action to make you upright. If your Achilles is not in action, you will not keep upright. Achilles is 3 muscles زي ما احنا عارفين. Mainly the complex بنسميها 3 muscles ليه؟ لأنه gastrocnemius has 2 heads. Medial lateral gastrocnemius and soleus. So they are 3 muscles, 3 heads going into one tendon. We need to understand the relation between the heads and the tendon. لو حضرتك بصيت على الصورة اللي في الليفت دي، فبasically they turn against each other 6 cm for insertion. So the medial head goes to the lateral side, and the lateral head goes to the medial side, and the soleus in between. وبالتالي it has this shape and insertion. Medial head going to the lateral side, lateral head going to the medial side, and this is a watershed area. And at the same time, makes the Achilles is a lateralizing force, is a valgus force, apply a valgus force on the hind foot. If you imagine this is the insertion of your Achilles, and you are standing, this Achilles, if you see the line of action of the medial is bigger and stronger, and the lateral is smaller, the gastrocnemius, and basically the medial is going to attach laterally, and the lateral is going to attach medially, and that's why your Achilles at this rotational area has a watershed area with low blood supply. This is the commonest to have the rupture, about 5 to 6 centimeters above the insertion, And at the same time, makes the lateral force, which is coming from the medial head, more stronger. That's why normally the Achilles is doing some valgus force over your heel. That's why with most of the heel valgus problems, we tend to lengthen your tendo Achilles. Soleus separately, rather than the gastrocnemius, has a very, very important role in gait. We'll explain it in gait, but keep it in your mind. What is the role of soleus? And you have to ask yourself, if there is a gastrocnemius with two big heads, why we need a soleus? This question, remember, I will answer it in the gait part. But you need to remember now that you have three heads, medial and lateral gastrocnemius and soleus, end by one tendon. This tendon has an inverted insertion. The medial insert in lateral insert in medial. The medial is more stronger, so the lateral force from the Achilles on the heel or the hind foot is more. That's why the Achilles is normally a valgusing force over the heel, and that's why we need to lengthen the Achilles when we're dealing with any valgus heel position or problem like the flat foot. Tani حاجة, you need to remember that this Achilles is a specific type of tendon, and ask yourself a very simple question. If you have an injury to one of your flexors in the hand, which is very, very small tendon, you tend to go and repair it. While if you have an injury to this Achilles, the huge tendon with a lot of stress, you sometimes treat it non-operatively. Very nice question. Ask it to yourself, and the answer simply is the type of the tendon. The flexor tendon in the hand is a sheath cover tendon, and the sheath cover tendon is a synovial sheath, has synovial fluid in it, and this synovial fluid makes the healing of the tendon much, much worse. And that's why the flexor tendons not heals nicely and easily. That's why we need always to go and repair them. While the Achilles is a paratenon covered, has a full layer of paratenon. This full layer of paratenon is a very good nutritional layer, and it's a very good conservative layer to the space. So when the paratenon is attached, even if the Achilles is ruptured, the paratenon still have the option to maintain the edges coapted. And even with a gap, it allows for a hematoma formation, granulation formation, and healing of the tendon because it has a good nutrition, good blood supply. So the difference between them, the flexor and extensor on your hand or your foot, are synovial sheath tendons. And this synovial sheath doesn't give a direct blood supply, but has synovial fluid in between, inside, which is against the healing of the tendon. That's why these tendons doesn't tend to heal conservatively. While in the Achilles, which is much bigger and in a lot of tension, a lot of stress, it is a paratenon covered, and this paratenon layer firstly maintain the tendon into aligned, and maintain even if there is a gap, this gap is contained inside the paratenon. At the same time, the paratenon is very well vascularized and is very have a very good nutrition, so it easily allow for a healing of the tendon even if there is a gap. But this ends by some lengthening of the tendon. That's why we can accept non-operative treatment of the Achilles, but we cannot accept non-operative treatment of a full rupture of extensor or flexor tendon in the hand or the foot. Again, Hussam, is it clear?
Yeah, it's clear.
If you look to the vascular supply to the Achilles, as you can see, so the Achilles is getting blood supply from the peroneal artery and from posterior tibial. Posterior tibial is covering up and down, and peroneal is covering the area of the watershed we spoke about. And as you can see, this blood supply is a bit of shitty blood supply with the mechanical position of the insertion. This makes this area very prone to be injured or to be ruptured. If you look to the insertion of the Achilles, you have a retrocalcaneal bursa, which is protecting the Achilles from rubbing against the posterior process of the calcaneum, posterior tuberosity of the calcaneum. And this is where it gets inflamed with Haglund deformity, which is abnormal prominence of this tuberosity. Then you have the subcutaneous calcaneal bursitis, which you tend to rest on it while you're sleeping. When you're sleeping, the subcutaneous calcaneal bursa is very important because it protects your heel from getting ulcerating. So you have a subcutaneous calcaneal bursa and you have retrocalcaneal bursa. And remember, you can easily differentiate between them. This will be at a lower level, just behind the posterior tuberosity. This will be at a higher level, above the posterior calcaneal tuberosity. Clinically, in the clinical session, I can show you how to differentiate between a Haglund and retrocalcaneal than a subcutaneous calcaneal bursitis. So these two types of bursitis are painful, are causes of the painful heel syndrome. This is retrocalcaneal, and is a bit high above the calcaneal tuberosity, and is very commonly to be there if there is a Hagland deformity. And the subcutaneous calcaneal bursitis is commonly, especially with tight shoes, especially the people who do marches and military services and something like that. So there are two different bursa, which makes two different syndromes. If we come to the surface anatomy, I need you to remember nicely the anatomy of the subcutaneous nerves. So basically, your saphenous nerve just go in front of your medial mal. Be careful while you're opening your medial mal not to go so anterior, because you have the saphenous nerve and the great saphenous vein. Remember that your superficial perineal nerve goes mainly along the lateral border of your fourth ray. So if you want to see your SPN or superficial perineal nerve, you need to ball on the fourth toe and ball on the fourth toe inverse or inversion. Then the superficial perineal will be prominent, and you can easily mark it subcutaneously, and I will show it to you when we're doing ankle arthroscopy portals. So remember that the saphenous is moving in front of your medial mal, and it can be injured during your incision. Remember that the superficial perineal nerve comes from above and moves along the lateral intermuscular septum, comes superficially around the lower fibula, and goes along the ankle lateral to the peroneus tertius, and then start to divide into branches, medial dorsal cutaneous and lateral dorsal cutaneous, and then the deep perineal give the middle dorsal cutaneous, which goes to the first web space. Sural nerve, it goes along the lateral border of your tendon Achilles, then it moves here just a few centimeters above the tip of your lateral mal, then it goes from here until it becomes the lateral dorsal cutaneous nerve. If we come to the foot, so your foot is three parts: hind foot, which is talus and calcaneus; midfoot, which is navicular, cuboid, and cuneiformis; and forefoot, which is metatarsal and phalanges. Very important to remember this differentiation, because a lot of my terminology, the coming terminology, will be speaking about every part differently: hind foot, midfoot, and forefoot. We speak about the tarsals. So the tarsals, basically, they are seven: talus, calcaneus, cuboid, navicular, and three cuneiformis. And remember that you have three columns of your foot: medial column, intermediate column, and lateral column. Medial column, which is the first ray. And remember, these have a very minimal movement, about 1.5 to 3.5 degrees of movement. This is very important. Why? Because basically we needed to move in the movement we spoke about from a minute ago about the tip post. So all the movement we needed from the first ray is to move in plantar flexion by the peroneus longus and the tip post, or move in a dorsiflexion by the tip end. And this is to create an arch and release it, create an arch and release it. Make your foot rigid, smooth, supple, rigid, supple, rigid, supple. So all the movement you need in the first ray is 1.5 to 3.5 degrees. If you come to the mid, it's nearly stiff, and this is very important because this is the main strut of your foot. Without this, your foot will not maintain shape, and without this, there is no medial arch, or medial longitudinal or lateral longitudinal. So because they are the main strut of the foot, they are nearly has no movement in their joint. So the second and third TMT joints moves about 1 to 2 degree only of movement, which nearly no movement. And this is why we tend to fuse the less frank injuries in young adults, rather than bridging them, because basically they are nearly physiologically fused, 0.6 to 2.6. And that's why if you come, if I say to you, if you are not a foot and ankle specialist, and I say to you, we prefer in young adults, especially in ligamentous injury, to fuse the less frank rather than fixing it. Fuse a joint which is supple, which is normal? Yes, because basically it is physiologically fused. It's just 0.6 to 2.6 movement. There is nothing there. And the foot gets more functional outcome from fixing this middle fragment, because basically you don't need to go and remove hard work. You don't need to go and do anything. And you're actually doing a proper fusion by fusing it at primary fusion rather than fixing it, which is like a delayed fusion. While on the other side, your lateral raise, which is the lateral column of your foot, has a lot of movement. And why? Because basically the arch on this side is low, and this is the side which accommodates the ground. So you need your lateral raise to be moving freely so they can accommodate the ground. So again, you have a medial column, which is the first ray. You have a mid column, intermediate column, or middle column, which is the second, third ray. and you have a lateral column, which is the fourth and fifth ray. First ray has some movement, about 3-4 degrees of movement, and this is very important for your foot to have an arch and relax, having an arch to be rigid, to make a rigid lever when you push off, and lose the arch when it needs to be supple to accommodate the ground. The mid column, which is the second, third TMT and metatarsals, needs to be rigid with very minimal movement, 1 to 2 degrees of movement, because basically it maintains the shape of the foot, and it is the main strut of the foot. On the outer side, your lateral columns moves about 9 to 10 degrees, 11 degrees of movement, because this is where you need to accommodate the ground when you walking. The medial column is basically starting from behind talus navicular medial cuneiform and first metatarsal. The lateral column on the other side, fourth and fifth metatarsal, cuboid and calcaneum. And when I ask you if you have like a severe lateralizing less frank injury, you say, okay, I will. If it's an adult, it's a ligamentous injury, I will be tending to primary fuse second, third, or even the first. But never speak about fusing fourth and fifths. If you fuse fourth and fifths, you will not be able to walk barefoot. So there is no option for that. Remember that you cannot fuse your fourth and fifth ray, and you cannot fuse your lesser toes MTB joints. And I will explain you why now. So basically, if you fuse the lateral column, there is no way for your foot to accommodate anything. It has a high medial arch, a low lateral arch, and they become fixed. Your foot will be like that. This is moving, very minimal movement on the medial side. Lateral is not moving, no way for your foot to accommodate the ground. You don't have any option except to have something soft under your foot, like insoles or soft trainers. You cannot walk barefoot because it will be very difficult for your foot to accommodate the ground. And on the other side, when you fuse this ray, which is the first ray or the medial column, you have to be very careful about where to fuse it, where to do a lapidus procedure, because if you fuse it in the wrong position, flexing, lowering the arch, you will end by flat foot, iatrogenic flat foot. So even if you have to fuse, you have to fuse it in this degree, which is 1.3 to 3.5, 1.5 to 3.5 degrees of flexion. So you maintain some sort of arch, but you still can fuse it because it is relatively fused, just have 3-4 degrees of movement. Second and third, you fuse freely because it's nearly fused. Fourth and fifth, no fusion. If you fuse them, even if you do something, you have to temporarily hold it and remove it later on, the metal work later on, because if you fuse them, you will not be able to walk normally. The arch is the very common Gothic arch from before. It has a key bone, or the keystone, which is this one, and the arch shape is maintained based on maintenance of each structure. You have medial, lateral, and don't forget you have a transverse arch. Medial longitudinal arch, which is maintained mainly by tib, post, and brevis longus, and lateral longitudinal arch, which is maintained mainly by brevis brevis, and brevis longus has a rule in it, and the transverse arch, which is maintained mainly by the ligaments, the plantar fascia, and the ligaments. And remember that this arch is very, very important, which we always miss. If you're going to fuse these three joints, which is first, second, third TMT joint, you remember you need to maintain this arch there. If you flex all of them, dorsal or plantar flex, you will lose this arch, and this will make your foot less accommodated to the ground and will put you in a problem. Remember to maintain this transverse arch. This makes your foot raise going in different direction. So the first is very plantarly flexed, less the second, less the third, fourth and fifth are nearly transverse. So if I'm going to do some vial osteotomy or do some osteotomy to shorten these metatarsals, you need to understand in your mind that they are not like that. They actually like that. Firstly is the most plantarly flexed, then the second, then the third, and fourth and fifth are nearly transverse. This is how the medial arch, the transverse arch, is formed. And this transverse arch has to be maintained for your foot to easily accommodate the ground. If you lose this transverse arch, you're accommodating the ground ability of your foot will be much, much less. حسام، الكلام ده ماشي ولا في حاجة؟
تمام يا باشا، مفيش أي كومنتات في دي، تمام.
الارش ده النورمال لونجيتيودينال ارش هو الاساس للفوت بتاعتك عشان تاكوموديت ذا جراوند او تويت بير نورمالي انت بتويت بير عند الفيرست ميتاتارسال هيد then moves to the fifth metatarsal head first MTB moves to the first metatarsal head, then goes back to the calcaneum or the heel. To do this, you have to have a normal arch. If you have a normal arch, you have a tripod. First MTB, fifth metatarsal head, and a heel. And you walk with this tripod. This tripod gives you the option to have a rigid lever when you push off. This allows you to move easily, allow you to translate from one step to another step in a very easy way. If you have a flat arch, you're loading the whole foot. Firstly, you put pressure on points which is not adapting to take pressure. وبالتالي البوينتس دي will be having pressure problems and metatarsалgia. Number two, you have a mid-foot break. You load the whole foot, which shouldn't be loaded. And rather than moving in a simple movement, in a simple transition movement, you will be moving like a plat movement. And the plat movement basically is زي ما احنا بنقول بالعربي كده يعني زي ما بتمشي بمشية البطة. So the arch makes you move with a tripod, first MTB, fifth metatarsal head, and the heel. And this gives you this picture. When we do a pedography or testing of pressure of your foot, you see that the foot doesn't load completely. There is an arch here and there is a small arch here, big arch here, small arch here. And you load the first MTB, the fifth metatarsal head, and the heel. If your foot is high arched, is a cavus foot or plantaris, this will end by you loading a lot on your forefoot, as you can see. So you mainly load the forefoot with less movement and somewhat on the heel, but there is nothing in the midfoot. And the other way around, if you have a flat foot, you'll be loading the whole foot as you see. These two are problematic, but if we come to the walking and gait, the flat foot is more problematic than the cavus foot. The cavus foot moves more quickly and less fatigability, but the flat foot, the patient will move with slower movement and more exhaustion and fatigability. So normal is the middle one, because this is because of your arches. If you lose any of the three arches, this is unfortunately a misconcept. So the people always speak about only the medial longitudinal arch, but this is not correct. For your foot to have the tripod, to load the 3 points which should normally load, you have to have the 3 arches maintained. So if you look in this picture, the medial longitudinal arch is maintained, the lateral longitudinal arch is maintained, and the transverse arch is maintained. If you lose any one of them, your footprint will not be the normal, so you'll be loading abnormal sides of your foot, which is not adapting to take weight, and this end by a pressure point, and this end by more fatigability and a slower movement. So the arches is there to give your foot a tripod shape, which makes you load less on the foot on a normal pressure areas, transit from one step to another step in very easy way by a rigid lever arm. And we will go through this in details in the gait one. So what maintains your medial longitudinal arch? The most important of them is the medial longitudinal arch. And to maintain the medial longitudinal arch, the key bone is your navicular, and the medial colon, as we agreed, is the talus, navicular, medial cuneiform, and first ray, which is the first metatarsal and the phalanges. For this medial longitudinal arch, you have a key bone, which is the navicular, maintained by 2 muscles, the tibialis posterior and the peroneus longus. Tibialis posterior is holding the navicular up, and peroneus longus is getting the first 2 down. So both of them are maintaining the same arch. With this dynamic, there is a static stabilizer of your medial longitudinal arch, which is the plantar fascia and the spring ligament. All the plantar ligament, but specifically the spring ligament, which is the calcaneonavicular, the plantar calcaneonavicular ligament, or the spring ligament, which is very, very, very important, and we'll speak about it separately in a minute. Your plantar fascia basically is a thick fibrous band starting from the calcaneal tuberosity and going in three it's 3 bands: central band, medial band, and lateral band. Central band goes to the middle toes, medial band goes to the first, and the lateral band goes to the fifth. So calcaneal tuberosity, where it's attached to, and then 3 bands: central band, medial band, and lateral band. Central band goes to the middle toes, medial band goes to the first, to the great toe, and lateral band go to the lesser toe. Where they insert, they basically insert into the blunter aspect of in the blunter blade of the first MTB and in the blunter aspect of the toe, and they do the very commonly called windlass effect. And windlass effect basically, if you remember الناس اللي تعرف الفلاحين لو انت عايز ترفع جردل، كانوا بيعملوا ايه في الجردل ده؟ بيعدوه على بكرتين، والجردل ده ينزل يعبي حاجات، ينزل يجيب ميه من البير ويطلع. بيجيب ميه من البير بيطلع ازاي؟ انت بتشد من الناحيه دي والبكر ده بيخليه يعمل windlass effect من الناحيه الثانيه. The windlass effect in your foot happens around the MTB joint. When your toe goes up, the plantar fascia get into tension, get the immediate longitudinal arch. This is again a main contributor in the gait. If you're walking, حضرتك عشان to walk, heel strike, loading, flat foot, then you do a push off. To do a push off, your first MTB has to extend. And for your first MTB, because the movement in the push off it is not at the ankle, it's in the first MTB. When the first MTB extend, this makes the plantar fascia tense, and this is get the longitudinal arch formed, and this is makes your talonavicular in a different plane than your calcaneocuboid. This makes your midfoot rigid, and this is allows the whole foot to be as the lever arm for the first MTB movement. أنا قلتها 10 مرات. It's very very important لأنها هتدخل في كل حاجة. الويندلس افكت بتاع البلانتر فاشيا بيزيكلي فكرة البكرة بالظبط، زي ما قلت لك موضوع الجردل والبيت ده. The plantar fascia is in the plantar aspect, attached to the plantar plates and all the toes. When you tend to push off, you push off by your mainly great toe and then start with the great toe, then go to the lesser toes. But if we speak about the great toe, you extend the great toe at the MTB joint, and when you extend the great toe at the MTB joint, you put the plantar fascia into tension, and when it is in tension, it pulls the medial longitudinal arch, create it, and when it creates it, it locks the movement between the talonavicular and calcaneocuboid, which make your foot as a rigid lever, so you can lever by your rigid foot and go and do a two-off. If the plantar fascia is not working, if the plantar fascia is not functioning well, is degenerative, ruptured, any problem, your midfoot, same as the tibialis posterior deficiency, will be breaking in a midfoot break while you're doing a push off, and this will make your walking less, more slower and more exhausting. On the other hand, remember that the plantar fascia is attached in the back to the Achilles tendon. So actually, it is a full complex. So the plantar fascia, 3-band, medial, lateral, and central band, and then they come to, as you see here, it doesn't go to the calcaneal tuberosity and stop. No, it goes and continue with the Achilles tendon insertion. And they are one complex. And that's why shortening in the tendo Achilles or contraction in the gastrocnemius soleus complex deposits for plantar fasciitis. And it's a very, very common missed cause. You have a patient with plantar fasciitis, you treat for years and years and years, choke with therapy, giving him medication, non-steroidal, even some people do PRP injection, non-steroidal, and patient is not responding. Not responding because you didn't do a cervical coil test. You don't understand that the problem of the plantar fascia, it is in a lot of tension because the contraction of the gastrocnemius soleus complex or the idiopathic shortening of the tendo Achilles, and they are one complex. Plantar fascia is attached to the tendo Achilles, and they all act as a one complex. If there is a contraction in your triceps suri or in the calf muscles, this will put plantar fascia under tension, and this ends by the plantar fasciitis. Remember, your plantar fascia is normally under tension because you normally have an arch. So the plantar fascia normally is under tension. That's why it's very common for the plantar fascia to have a plantar fasciitis, especially in obese people, cavus people, people who are long standing for any reason, their profession is long standing. And the problem with the plantar fascia is mainly insertional. So your plantar fascia is always painful here on the old days, what we call calcaneal spare and stuff. Calcaneal spare is the degeneration with calcification on it. It doesn't make any sense. It doesn't mean anything significantly. But there is a very common plantar fasciitis. The most common plantar fasciitis is insertional plantar fasciitis because basically this is the area with the maximum tension. So the 3 bands works together on this area, and this area is commonly to have the main tension, and that's why you commonly have the insertion of plantar fasciitis. Added to this area is the most watershed with less blood supply. So your plantar fascia is normally under tension. It's a fibrous sheath, central band, medial and lateral bands. They attach it to the plantar plate and the plantar aspect of your toes. With the toe extension at the MTB joint, the windlass effect happens and the plantar fascia tightens. And when it tightens, it creates an arch, and creating the arch, lock the foot, and locking the foot makes it a rigid lever, and this allows you to toe off and continue your normal gait. It's commonly to have an insertional plantar fasciitis, and this is because this is the watershed area and the area with maximum tension. Number two, remember that the plantar fascia is one complex with your Achilles, so plantar fasciitis is commonly to happen with contracture of the gastrocnemius or shortening of tendo Achilles. حسام, we're going okay ولا في حاجة؟
I think we can carry on, yeah. There's a question, but I think it can be covered in another lecture.
No, it's fine. The question, which is
surgical option to correct the flat foot or maintain the medial arch.
That's fine. Now, any question away from a point is unclear, I will answer at the end. Anyone feeling any point unclear, please stop me. All the lecture depends on each other. This is the whole anatomy, is the whole ankle and foot. So if you miss one point, you will be missing another point where we're going forward. So please don't let me go forward unless you following me. Okay?
Yeah.
Write in the chat, and Hussam will pass it to me. And unfortunately, I couldn't see any chat because the screen is just full screen. Okay, come to the tails. If we start to speak about the hind foot, you need to remember you have the talus and calcaneum, and the talus and calcaneum are very unique bones and have a very unique relation. So the calcaneum is different than all your bones. If you have a lock on it, it has a body and a neck and a head, and then a lateral and posterior process. They are not on the same line. So basically, the neck and the head are inverse. They are going a bit medial, projecting more medial, and the lateral process is projecting more lateral. Remember that is covered in 2/3 of it by cartilage. Head is completely covered, body is completely covered, lateral process is covered, and other than this, because it's mainly it's mainly a transmission bone. So all the job the talus does is to change the movement of your tibia onto your foot. So, and I'll explain this to you in details. So the talus is basically a hinge, basically مفصلة. اللي التالس بتعمله اسمه مفصلة ما بين الموفمنت بتاع التيبيا والليج والموفمنت بتاع الفوت. There is no muscular attachment. Remember انه في البوستيريور process بتاعها there is a groove where the flexor hallucis longus pass, and the lateral tubercle is the common site for osteogonum. And that's why the osteogonum is also always lateral to the FHL. Remember انه البody is not uniform, it's trapezoidal, broad anteriorly. That's why when you put your ankle in dorsiflexion, you tension the ligaments around the ankle, and the ankle is more stable. And remember that talar neck connect the body to the head, and the talus had 3 fossae to connect to articulate with the calcaneum, posterior fossa, middle fossa, and anterior fossa. If you come to the blood supply, which is very, very important for the talus, so the main artery which supplies the talus is the artery of the tarsal canal, and this is coming from the posterior tibial. So posterior tibial give artery of the tarsal canal, anterior tibial give branches to the talar neck, and then give the artery of the sinus tarsi, anastomose with the artery of the tarsal canal, and this is where main blood supply to the talus comes. So as you see, posterior tibial, artery of the tarsal canal, and anterior tibial give artery of the sinus tarsi. They anastomose inside the sinus tarsi, and this is where the main blood supply of the talus comes. You have some perforator from the perineal artery. You have some supply to the neck from the anterior tibial, or the dorsalis beads actually. But the main supply is from artery of tarsal canal of posterior tibial and artery of sinus tarsi of the anterior tibial. Remember إنه blood supply الكلمة دي مهمة قوي. Blood supply to the body is retrograde. how is retrograde? Posterior tibial is coming from the back, anterior tibial is coming from the back. How the blood supply to be retrograde? Yes, retrograde to the body, not to the talus. Because as you see, the artery of the tarsal canal, the anterior tibial, the perineal, the perforator perineal, the artery of the sinus tarsal from the anterior tibial, all are in front of the body. And they go through this vascular foramina in the neck and goes from the neck back to the body. That's why the body of the talus is the least supplied by blood, because it's a retrograde supply. And when you go up, so the top of the talar body or the articular surface is the least one with blood supply, because the highest point basically لو حضرتك تخيلت retrograde blood supply, كل blood supply جاي من ورا من قدام لورا and it has to go up. فمن قدام لورا ده against the gravity, against the normal push, normal pressure inside the artery. Number two, it goes from down up against gravity again. That's why the top, especially the shoulders of the talar body, is the least supplied by blood. وده اللي بيخليك very common تشوف الهوكن sign when you have a talar fracture and start to revascularize. The revascularization goes to the least vascular area, which is the talar body, especially medial and lateral shoulders, and this creates the Hawkins sign. The second point, you need to understand that all the blood supply is mainly above the neck. And when you have a neck fracture, then this blood supply is badly affected. So artery of the tarsal canal, artery of the sinus tarsi, anterior tibial branches to the neck, perforator of the perineal artery are all on the neck of the talus. So with talar neck fracture, the blood supply to the talus is badly affected, especially the blood supply to the talar body, which is retrograde. In the X-ray, this is the talar body, this is the neck, and this is the head. It's easy to recognize this. Then calcaneum is another unique bone. You need for the talus and calcaneum. Unfortunately, I don't have a model, but I have to show it in the model. If you have to hold the calcaneus and talus in your hand to understand the anatomy, how is the direction, how the neck goes in varus, how the calcaneum has a rotational surfaces, and how they articulate with each other is very unique. And this unique configuration of the bone and configuration of the articulation surface, what makes them transmit the movement, the rotational movement of the leg into rotational movement of the foot. It's not normal to move the rotational, they are different planes. Rotation of the leg in this way, and rotation of the foot is varus valgus, or eversion inversion. So the leg rotating internal and external, and the foot rotating in inversion, and they are connected. How they are connected? By the unique configuration of the talus and calcaneum and the unique relation between them at the subtalar joint. So you have to hold the talus. If you have an option for a sawbone or something, of any of you who will be attending the Egyptian Orthopedic Congress, I will show them this in the workshop. You have to hold the talus in your body, in your hand. You hold the calcaneum in your hand and see the shape and how they are beautifully formed, subhanAllah, and how the articulation is very uniform. And because of the uniform shape and uniform articulation, the talus and the calcaneum are able to change the movement, the rotational movement in this plane, in the axial plane in the tibia, to a rotational movement in the coronal plane in the foot. So from rotation in the axial plane to rotation in the coronal plane, this beauty happens because of this special hinge, which is the unique talus, unique calcaneum, and the unique subtalar joint. So if you look at the calcaneum, it has a posterior facet, it has a medial facet, and it has an anterior facet. وركز معايا قوي في شكل الفاسد. So if you see the shape of the facet, you can easily recognize that the posterior facet is curved, and is curved this way. So the movement it allows is in and out. So it allows eversion, inversion. While the medial facet is this way, oblique way. So it allows to move up and down. And moving up and down gives you the movement of plantar and dorsiflexion. And anteriorly, the calcaneal process is oblique in this plane. So it allows the movement of the midfoot in and out. So 3 facets, every facet has a different configuration which allow a different plane of movement. Posterior facet, which is larger posterior facet, which is allows for movement, for transition movement mediolateral, which give you the movement of eversion, inversion of the hind foot. Medial facet, which is in oblique position, allow the talus to move up and down on the calcaneum. Then anterior process, which allow this movement of the midfoot in and out. So 3 planes of movement, 3 different facets, every facet in a plane allowing a certain movement, eversion, inversion, up and down, and in and out. So basically, eversion, inversion is coronal, up and down is sagittal, and in and out is axial. So posterior facet allows you to move in a coronal plane, medial facet allow you to move in a sagittal plane, anterior facet allow you to move in an axial plane. And you see this unique relation there. For the talus, for the calcaneum to move under the talus, it never ever moves in one direction. That's why the subtalar joint doesn't give you eversion, inversion. It actually gives you supination, pronation. And we'll explain this in details. Why? Because of the orientation of the facets. It's not a one facet which allow a movement. It's actually three facets in three different planes given three different movements. As I told you, eversion, inversion in the posterior facet, flexion, extension, or up down in the middle facet, and in out or adduction, abduction at the anterior facet. That's why your foot never move in one way. كل واحد في حضراتكم يحاول يحرك رجله ويبص لو عمل بلانتر فليكشن ايه اللي هيحصل، لو عمل دورس فليكشن ايه اللي هيحصل، ويقول لي هل يقدر يعمل ايفرشن انفرشن بس، يقدر يعمل بلانتر فليكشن دورس فليكشن بس، يقدر يعمل abduction adduction of forefoot بس؟ يستحيل. He has to move the foot in the three planes at the same time, and this is unique for the shape of the talus, shape of the calcaneum, and the subtalar joint. We'll go to this in details, don't worry, but just to try it. Calcaneum, the most important areas of the calcaneum you need to understand, definitely the facet, so middle facet, posterior facet, middle facet, and anterior facet. It has an anterior process which has articulation with the cuboid and the navicular, and it has a very dense eminence on the undermedial surface, which is the sustentaculum tilli. It's actually this one. This sustentaculum tilli is basically because, as I told you, you normally, when you start to dynamically move, your foot is normally, heel is normally in varus. So a lot of stress over the medial aspect, compression stress. If you go and remember what I told you about the deltoid and lateral ligament, when you start to walk, your heel is normally in varus. So there is a tension over the ligaments on the lateral side, compression over the bone on the medial side. That's why the sustentaculum tilli is a dense sclerotic bone on the medial aspect of the calcaneum. Why? Because your foot tend, while you dynamically move, to be in varus. So the compression stress is more on the medial aspect, while your lateral ligament are more prone to injure because there is more tension stress on the lateral aspect. Sustentaculum has FHL moving underneath it in a groove, and this is very commonly to be injured if you are doing fixation either omopectineus, because you do your fixation from the lateral aspect, the tip of the screws are on the medial aspect, and if the tip of screws miss the sustentaculum tilli, goes underneath it, they will injure the FHL. So sustentaculum tilli is very important surgically for us because this is where we build the calcaneal fixation on. Calcaneum is a cancellous bone, and when it gets injured, it crashes into pieces. And the base to build on is a sustentaculum tilli, which is a dense sclerotic bone. You can easily hold the all other fragments to it, but you need to be careful because underneath the sustentaculum, the FHL is just going and easily to injure it by the tip of your screw, especially if your screw is long. And the sustentaculum is in this position anatomically, subhanallah, because you put dynamically more varus stress on your ankle, more varus compression stress in your ankle, and more varus tension stress on your lateral ligament. That's why you have a sustentaculum, which is a dense sclerotic bone on the medial aspect, and lateral ligament, which are more prone to injury because you put more compression medially and more tension laterally because you dynamically, your foot is normally heel normally is in varus. حسام الحته دي برضه is very very important.
Yeah, it's clear. Clear. No question on it.
Good. If we go to the subtalar joint, as I told you, is very unique, and because it's very unique, this is how it moved. As I told you, how it translates the movement in the axial plane to a movement in the coronal plane. And this is the position you see. It's basically posterior facet, which is convex here, concave here, allow varus valgus inversion. I'm sorry, eversion inversion or varus valgus. Medial facet, which allow the calcaneal and the talus to move up and down on each other, and then the anterior facet which allow them to move in and out. They are controlled by 4 ligaments, so medial ligament, lateral ligament, interosseous taloocalcaneal ligament, and the cervical ligament. And cervical is the anterior interosseous ligament. You don't need to remember them. Remember, there are medial, lateral, and interosseous. Interosseous, the anterior part of it is a cervical ligament. Remember that this calcaneal anatomy is very important. Normally, the orientation of your heel and hind foot is the calcaneum are not directly under the tibia. So tibia had the talus directly underneath, and the calcaneum actually translated a bit lateral. And this is, again, both more compression stress on the medial side, more tension stress on the lateral side. And that's why to maintain this relation is a very, very crucial to maintain the alignment and don't have any problem from alignment. You need to understand this. You don't wait for your tibio-talocalcaneal to be one line. They are not one line. Normally, tibio-talar is one line and calcaneal is already translated a bit lateral. Remember this, very, very important again. And this plays a big role in the mechanics because this makes you, during dynamic movement, heel is in varus, a lot of stress, tension stress on the lateral, compression stress on the medial. And this is either explained you. This is the leg and this is the foot. And this hinge, this is the unique hinge, which is talus subtalar calcaneum. The 3 of them are unique in configuration, and this is why they allow rotational movement in the leg in axial plane to be a rotational move to be translated into a rotational movement in the coronal plane in the foot. And this is what I explained you. Go back, move your foot, and you will find that there is no way. Once you plantar flex, what your foot does, invert and adduct. Plantar flexion, inversion, and adduction, and the other way around. If you dorsiflex, automatically your foot will go into eversion and your forefoot will go into abduction. Again, plantar flex, inversion, adduction. Dorsiflex, eversion, abduction. Move your foot and tell me what you find. How this happens. So basically, I have to have a model. Next slide. Ankle. And when you start to walk, basically if you try to plantar flex, what will happen? We agreed that talus is wider anterior, the talus body is wider anterior and narrower posteriorly. When it plantar flex, it allowed the talus to move into the ankle, to translate into the ankle. Once it translates into the ankle, the posterior facet of the subtalar will get the heel into varus, and this automatically will get the middle facet to move the heel, to move the foot, the midfoot into more plantar flexion, and the anterior facet, the talus will move in the anterior facet with the whole foot into adduction. So plantar flexion, inversion, adduction, and the other way around. If you go with the talus up, you dorsiflex. The talus, when it dorsiflex, the talus is fixed into the ankle. There is no movement, and this time the calcaneum has to move. So the posterior facet allow the calcaneum to go into valgus, and then the mid facet allow the calcaneum to move the midfoot up, and the anterior facet allow the foot to abduct. And the same process happens dynamically with the ligaments and the tendons. So when you go into plantar flexion, your tibialis posterior is put into action. So what it does, it creates an arch, which equal that your heel will be in varus, your forefoot will be in adduction, because it is attached to navicular, cuneiform, and mainly navicular and cuneiform. So basically, attached to the navicular, so it does evert, and attached to the cuneiform, it does abduct. And dynamically on the other side, when you dorsiflex, Brennius brevis goes into action. So what it does, it basically everts and abduct because it's attached to the base of fifths. Okay. Joint wise, bony movement, ignore the muscles and tendons. Bony wise, talus and plantar flexion, loosen the ankle, slides into posterior facet, heel goes into varus, medial facet allow the midfoot to plantar flex, and the anterior process facet allow the talus and the whole foot to go into adduction. Other way around, talus up, dorsiflexion, tighten the ankle, heel start to move into eversion, middle facet allow the forefoot to go up, midfoot to go up, and then the anterior process allow the forefoot to go out. So plantar flexion, inversion, adduction. Dorsiflexion, eversion, abduction. Muscle action, plantar flexion, tib post in action, move the navicular up, get the whole heel in varus, and the whole forefoot into adduction. Other way around, dorsiflex, peroneus brevis in action, move the heel in eversion, and get the whole forefoot into abduction. And this is the beauty of Allah. This is beauty of khalq Allah subhanahu wa ta'ala. Because basically, you need the both actions doing by this way, otherwise you will never walk. Plantar, when you go in the gate, heel strike, your foot start to load, flat foot. At this moment, flat foot equal what I do. When you flat foot, what do you do? What do you do? Well, no. When you basically when you do blunt, you do loading. Basically, you dorsiflex the ankle. Foot is on the ground, and the ankle is dorsiflexing. And when it dorsiflex, بس مركزوا معايا. الفوت in the ground مش بتتحرك، اللي بتتحرك البودي، وبالتالي الانكل ريلاتيفلي بيدورسيفلكس. بيزيكلي البودي بيتحرك على الفوت، وبالتالي كأن الفوت عملت دورسيفلكشن. فالميد الهيل جوز ان ايفيرشن او فالجس، الفورفوت جوز ان ابدكشن. ده بيعمل ايه؟ makes the calcaneal cuboid in parallel with the talonavicular. Your foot is supple, accommodates the ground. والمسألة دي is reverse when you push off. Pushing off means you plantar flex, tip post in action, you invert, and you adduct. So your forefoot, the talonavicular, is not in the plane of the calcaneal cuboid. Your forefoot is rigid, so you can push off with it. So you need the two action in time for the gait to be efficient. Flat heel strike, flat foot. After the flat foot, loading means your body move over the ankle, so the ankle is relatively dorsiflexed. And when it is relatively dorsiflexed by the bony movement and the tendon movement, peroneus brevis in action, as we told from a minute ago, your ankle goes into eversion, your foot goes into abduction, your midfoot joint, chopper joint, which is talonavicular, is in line with the calcaneal cuboid, your foot is supple, accommodates the ground. This goes in reverse when you push off. Pushing off, basically, you plantar flex with the action of the tip post and the talocalcaneal movement. Your foot goes, the heel goes into inversion, your forefoot goes into adduction, your talonavicular is not in line with the calcaneal cuboid, your midfoot is locked, your foot is a rigid plate to push off. Anyone didn't get this point, I can repeat it the whole night. This is the main message of this lecture. Any comments, Jose?
Yeah, there is no comments.
Sure. يعني
No comments till now.
لو الناس فاهمة ده يبقى أنا يعني عملت إنجاز. No comments عشان أحمد شعلان هو بيسأل how in and out.
Wow, it's clear after that. Okay, it's clear now. Thanks.
Okay, طيب. Okay. Moving forward, midfoot. حسام اتأكد كده كل الناس الموجودة عرب ولا فيهم حد تاني؟
لا كل لا كله عرب.
طب طيب تمام.
ما فيش أجانب، لا كله عرب.
الكيوبويد زي ما حضراتكم شايفين شكلها كده is cuboid, is box, is like a cuboid, is cuboid in shape, has a connection مع الكالكينيوم in the back and مع الفورث والفيفث metatarsal in the front. This facet for the calcaneum زي ما اتفقنا it has a groove for the peroneus longus, had a tuberosity on the lateral aspect where this is to connect with fourth and fifth metatarsal. The navicular is very important. Remember these pictures to show you that the cuboid and navicular are not the one you know. Cuboid and navicular are very big bones. When you go and fix, you will see the navicular is a really big bone, and it has this wedge shape, or what we call semilunar shape. Navicular has a medial plantar projection, which is insertion for the hip post, with the most important. Sometimes النافيكولار دي already بتطلع من two ossification center. Sometimes the two ossification centers دول either don't fuse or they fuse, but in the fibrous non-union, and that's why you see the accessory navicular. And the types of the accessory navicular is either completely separated, as type 1, or like it resembles a non-union like type 2, or it's actual hook as type 3. In the navicular, you have an attachment site for the first cuneiform, second cuneiform, and third cuneiform, and definitely on the back you have an articulation with the talus. So the back articulates with the head of the talus, and the front articulates with the third cuneiform. And as I told you, on the lateral aspect, it has a facet for the cuboid and anterior process of the calcaneum. The relation between the navicular and the cuboid اللي احنا بنتكلم عليها من ساعتها هي الميد فوت جوينت او الشوبر جوينت. شوبر جوينت اللي هو التيلو navicular and the calcaneocuboid. When your foot is flat, you have parallel relation between the talonavicular and calcaneocuboid, وبالتالي the foot is supple, easy to accommodate the ground, and the reverse if the foot is if the arch is formed when these two planes are different, so the foot is rigid. Ligaments of these are dorsal and plantar. The bifurcate ligament come from the anterior process of the calcaneum to the navicular and the cuboid, and this relation is a very fixed relation. That's why your foot, the center of rotation of your foot is the head talus and the talonavicular, because navicular, cuboid, all the forefoot definitely, navicular, cuboid, and calcaneum, they move as a one unit, and that's why all the deformities are from the talonavicular joint. That's why when you have a clubfoot or talibus equinovarus, the actual deformity is in the talonavicular. That's why we use the talar head as a center of correction, because basically the whole fore and midfoot move and hindfoot moves around the head talus. That's why you have the cavus, adductus, and varus, and definitely the equinus. So all the deformities you will see is actually the center or the cora will be in the talonavicular. The whole fore and midfoot moves as one unit on this cora. زي ما قلنا في dorsal and plantar ligaments, and there is a bifurcate ligament طالع من anterior process of the talus to the navicular and the cuboid. If we come to the cuneiform, the most important طبعا is medial, intermediate, and lateral cuneiform. You need to understand that the second metatarsal is the longest, so it recesses backward, وبالتالي this curve is arching itself. second TMT joint is more proximal to the first and third TMT joint زي ما حضرتك شايفين, and the joint between the cuneiform and the second metatarsal is the least frank, what we call the least frank or the tarsometatarsal. The least frank is we speak mainly about this interosseous ligament, but actually it is a ligament complex. It's a dorsal, plantar, and interosseous ligament, and actually it has an accessory ligament to the third metatarsal base. So least frank, not as we imagine, it's one ligament between the medial cuneiform and base of second. No, it's actually a ligament complex with dorsal, plantar, and interosseous part between the medial cuneiform or the first cuneiform and the base of second, and has an accessory ligament to the third base of third metatarsal. what we see here in the cadaver, the number 6 and number 7, these are the Lisfranc joints. The Lisfranc, I'm sorry, complex, or the Lisfranc ligament. Is this relation is very important? Yes, and that's why your Lisfranc injury needs to be treated. Why? And if it's commonly missed, and if it's missed, the patient come always with midfoot pain. Why midfoot pain? Because he lost the transverse arch. If this transverse arch, the key bone is the second metatarsal base, and if you lose this Lisfranc complex, the whole transverse arch will collapse, and this will end by midfoot break, and that's why the patient will come to you with a chronic midfoot pain. The patient with missed Lisfranc will come to you with a chronic midfoot pain, and this is because this arch has been lost. For the metatarsal, all I need you to remember is the first metatarsal and the sesamoid, and the sesamoid metatarsal-sesamoid joint. Remember, this is the normal shape. You have a tibial and a fibular sesamoid. The tibial sesamoid, the medial sesamoid, fibular sesamoid is the lateral sesamoid. This is their normal place. If this normal place it changes, this means the head is moving into varus, and this is when you diagnose a hallux valgus. And this is what you need to correct when you correct the hallux valgus. You need the metatarsal, the sesamoid to be covered by the head of the metatarsal. So you need to maintain this normal relation to have a normal weight bearing on the first MTB. Without this normal relation between the sesamoid and the metatarsal, there will be abnormal loading here, and this ends by disturbed mechanics, and this is where the hallux valgus starts. So hallux valgus starts because of disturbance of this mechanics. And when you need to correct hallux valgus, you want the sesamoid to be completely covered by the head of metatarsal. As you can see, this is the sesamoid view. You can see there is a cresta here, two cresta, medial and lateral. Medial cresta is for tibial sesamoid, lateral cresta is for lateral sesamoid. It's a very, very common missed cause of lateral first MTB pain because of the sesamoiditis. So remember the sesamoiditis, remember the sesamoid view. As you can see, you understand definitely that the sesamoid are an accessory bone in the flexor hallucis brevis tendon. And as you see this complex, the flexor hallucis brevis tendon has medial and lateral sesamoid in them. There is inter-sesamoid ligament, and there is inter-metatarsal-sesamoid ligaments on either side. And this is what we call the sesamoid ligament complex. And this is very, very important to maintain the two balanced. If you lost one of them, so you get a sesamoiditis or a fracture in the lateral or fibular sesamoid, you go and remove the fibular sesamoid, this toe will go into varus. Because basically it lost this part of the complex, so it's not balanced anymore. The varus force from the intact ligament complex on the medial will overcome the lateral and end by the toe into varus, and the other way around. If you lost the medial sesamoid or the tibial sesamoid, this part of the complex will be lost, and the other part is still intact, so it falls into the toe into valgus. If you come to the phalanges, I need you to remember the shape of the joints. This is not for anything. And remember, this is an arcade. So the second is the longest, and the first is shorter. And if you actually come, so the third is shorter than the second. The first is shorter than the third, and the fourth is shorter than the first, and the fifth is shorter than the fourth. So second, third, first, fourth, fifth. Second, third, first, fourth, fifth. And this is the normal arcade. And if you're doing a transmetatarsal osteotomy, amputation, you need to maintain this normal arcade. You need the second metatarsal to be longer. You need after the second, the third, after the third, the first, after the first, the fourth, and after the fourth, the fifth, because this shape gives your foot the unique shape which make it showable, makes it goes into shoes. If you look into your shoes, you'll see that the shoes is prominent from the center, not from the sides, and shorter on the medial side and more shorter on the lateral side, because it needs to recreate the shape of the arcade, which is longer second, and then an arcade is coming second, third, one, four, fifth. Very, very important for the MTB joint is to understand the plantar plate. Plantar plate is not a simple structure. It's a very complex structure. It's a fibrous plate. It's the main stabilizer of the MTB joints. When we speak here about the first MTB as an example, the plantar plate is it's very strong fibrous sheath. It's connected to the metatarsal by two bands, as you can see, and connected to the phalanx by one band. So two bands to the metatarsal and one band to the phalanx. receives the attachment of the transverse metatarsal ligament, it receives the attachment of the plantar fascia, and it is the main stabilizer of the toe not to float up. So basically, to understand this, you need to understand that the long tendons are working on the IB joint, not on the MTB. The long tendon, so long extensor or long flexor, they work on the IB joint, BIB or DIB. They don't work on the MTB. MTB is mainly controlled by intrinsics, and the intrinsics tend to flex it, to extend it, and the plantar plate is the one which maintain it into stabilized. That's why when you lose the plantar plate, your toe will go up, and this is the mechanism how the hammer toe happen. When you have an hallux valgus, you transfer the load from the first. When with hallux valgus, because it's pronated like that, the hallux is short, and the first metatarsal is elevated than normal. That's why the transfer metatarsalgia happened to the other toes. With transfer metatarsalgia, the plantar structure starts to attenuate. When the plantar plate attenuate, this is how the MTB goes into extension. With the ball of the flexors, the toe go into hammering or even into clawing, which is like that. Again, the plantar plate is a very strong fiber. It's the same in the hand. It's here. That is very strong fibrous plate. Has two limbs attached to the metatarsal, one limb attached to the phalanx. It receives the attachment of the intermetatarsal ligament, transverse intermetatarsal ligament, and the attachment of the plantar fascia in the foot. If this attenuated for any reason, the commonest is when you have an hallux valgus, the metatarsal head is elevated, is not getting the load. The load goes to the lesser toes. They are not adapting to get to load. That's why the plantar blades start to attenuate. When it starts to attenuate, it allows the MTB to extend, and the flexor tendon pull the toe into flexion, so give you the characteristic hammer toe. And this is the main pathological way of getting the hammer toe with hallux valgus. Plantar plate, if there's no disease, if the patient is not doesn't have a rheumatological problem, it's easy. It should be repaired. The problem with the plantar plate that it sometimes miss only one of the limb, either medial or lateral. If it miss the medial, the toe will go into valgus, and if it miss the lateral, the toe will go into varus. If miss both or both, or the plantar plate is attenuated, the toe will float up, and when it's float up, it goes on hammer or claw toe. Remember that the transverse metatarsal ligament has the lumbricals underneath and the interossei above. And remember that the nerve goes underneath the transverse metatarsal ligament, and this is where the mortals neuroma happen. So this is the shape of your MTB joint. So you have the flexor tendons underneath, the extensor tendons or the extensor hood up, metatarsal head. And remember that transverse metatarsal intermetatarsal ligament has the interossei above, the lumbricals, and the digital nerve underneath. Because the digital nerve is underneath, with any cause of overloading of your forefoot, you put more load on the transverse intermetatarsal ligament, and this is when the nerve gets degenerated and form the Purcell complex, what we call the Morton's neuroma. So Morton's neuroma happen because the nerve is passing underneath the intermetatarsal ligament, and with any cause of overloading the forefoot, you push more on the forefoot. The intermetatarsal ligament, the nerve gets injured not injured, this get overloaded between the intermetatarsal ligament and the ground, and that's why it's common to have the Morton's neuroma. As you see, if we speak about the tendons, you have long extensors, AHL, ADL, AHB, ADL, AEDB, and the flexor on the other side, FHL, FDB, FHL, FHB, FDL, FDB. The long extensors, as you know, goes up to here, then it goes into an extensor hood. The extensor hood, as you see, is getting the long extensor, the short extensors, and make the hood, which is attached by single band to the base of middle phalanx, and then these two bands come into two bands. They come together in one end, which attached to the distal phalanx. This is very, very important. It has two oblique bands here, and it has two transverse oblique bands here. These transverse oblique bands, which led these extensor bands to be in place. If you miss this one, this extensor band will move up, and when they move up, they allow your toe. They don't do the action anymore because they are not in the line of the action. So extensor hood, longest and brevis make the hood. The hood has a transverse bands holding them here, then the oblique bands holding from the side. They go, as I told you, as two bands to the base of middle phalanx, and they continue as one band to the base of distal phalanx. You have 4 layers in your foot. Every layer has a certain muscle and tendons. To remember them easily, remember that 2 and 4 has the long tendons, 1 and 3 has the short muscles. So layer number 1 has an abductor hallucis and abductor digiti minimi and flexor digitorum brevis. Remember that the axis of the foot is just beside the second toe. So everything which you pull this way is abductor, and everything which you pull this way is an abductor. So abductor doesn't mean to the axis of the body, but to mean to the axis of the foot. So your mid-foot axis is there. So this one is abductor hallucis, and this one is abductor digiti minimi, though they are moving in 2 different directions, because they move the hallux and the digiti minimi away from the mid-axis of the foot. We are not calculating with the mid-axis of the body as we normally do. So mid-axis of the foot is just beside the second toe. Anything which moves away from the mid-axis of the foot is abductor. Anything moves to the mid-foot, to the mid-axis of the foot is adductor. So first and third layer, you have the short muscles. Second and fourth layer, you have the long extensors. So first layer, you have abductor hallucis, abductor digiti minimi, and flexor digitorum brevis. And on the third layer, you have the flexor hallucis brevis, you have the flexor digitorum brevis, digiti minimi, and you have the adductor hallucis. First layer, abductor hallucis, abductor digiti minimi, flexor digitorum brevis. Third layer, flexor digitorum digiti minimi, flexor hallucis brevis, and adductor hallucis. Long tendons on the second, which is long flexor hallucis longus and flexor digitorum longus, with added to them the lumbricals, because they are attached already to the flexor digitorum longus, and the quadratus planti. Don't worry about it. But remember that the second layer has long flexors, flexor hallucis longus, flexor digitorum longus, and the flexor digitorum longus has the lumbricals attached to it. Layer number 4 has the tibialis posterior, again long tendons, tibialis posterior, and peroneus longus, and the interossei. So 4 layers of the foot. First and third layer has short muscles. Second and fourth layer have long tendons. Layer number 1, abductor hallucis, abductor digiti minimi, flexor digitorum brevis, and remember abductor to the central axis of the foot, not to the central axis of the body. Number 3 has a flexor hallucis brevis, flexor digiti minimi brevis, and adductor hallucis. Layer number 2 has long flexor hallucis longus, flexor digitorum longus, and with the flexor digitorum longus, the lumbricals and the quadratus planti. And on the other side, layer number 4, tibialis posterior, and peroneus longus, and the interossei. Remember the accessory bone. So accessory navicular, as we agreed, is actually a center of ossification, which either hasn't united or united with fibrous union, osteoregonum and osperineum. And osperineum is in the peroneus longus tendon, and osteoregonum, as I told you, just lateral to the FHL. Ossification, just remember that calcaneum come in the 6 months. Calcaneum, talus, cuboid, medial cuneiform, lateral cuneiform, intermediate cuneiform. Remember it like that. I will not go into the numbers. Remember that the nerve supply of the foot, so medial malleus is supplied by saphenous, then lateral malleus is supplied by sural, and all the dorsum of the foot is supplied by SPN, superficial peroneal nerve, except the first web, deep peroneal. And remember, it is the reverse in the hand. So in the hand, the first web space is supplied by radial, and the others are supplied by medial ulnar. Here is the reverse. Here is superficial radial. Here is deep peroneal. So in the hand, the first web space is supplied by superficial radial. In the foot, the first web space is supplied by deep peroneal. Then the bluntal aspect of the foot, you have here the medial calcaneum, which is coming from the posterior tibial. The posterior tibial is divided, or tibial nerve is divided into 2 parts: lateral peroneal, lateral plantar, and medial plantar. Remember, and it's again the reverse from the hand. For the hand, the median is supplying the 3.5 fingers, and the ulnar supplying 1.5. Here, the medial is supplying 3.5, and the lateral is supplying 1.5. So to remember it easily, medial malleolus is saphenous nerve, lateral malleolus is Schurer nerve. Calcaneum has 3 branches: lateral, medial, and mid calcaneum. Medial calcaneum is coming from posterior tibial or tibial nerve. Remember, in the whole dorsum of the foot supplied by superficial perineal, except the first will be space by deep perineal. Reverse is in the hand. First will be space supplied by superficial radial. Superficial in the hand, deep in the foot. And in the hand, 3.5, the lateral 3.5 supplied by the median, and the medial 1.5 supplied by ulnar. The reverse in the foot, so the medial 3.5 supplied by the medial plantar aspect, and the lateral 1.5 supplied by lateral plantar nerve. You have 9 compartments in the foot. So central compartment, which has 4 interosseous compartments, as you can see, and then superficial, middle, and deep central. Then you have medial compartment and lateral compartment. Medial compartment, lateral compartment, central compartment into 4 layers: interossei, deep, middle, and superficial. So all are 9. And if you want to open them, you have to open them from 3 incision: long medial incision, and incision over second and fourth metatarsal. And second and fourth metatarsal allow you to go to the interosseous compartment, deep and middle compartment, medial and lateral, and the medial one allows you to go to the medial, to go to the deep, intermediate, and superficial central. Complication, the problem with the fasciotomy of the foot, it always complicated by chronic pain and hypersensitivity. So you haven't had anything, you may have fixed flexion deformity of the digits. That's why a lot of the people speaks about should we do an acute decompression of a compartment syndrome of the foot or not, if the patient will end by the same problem with fasciotomy or without. So that's why the post guidelines say there is no consensus over how to manage a foot compartment syndrome. Most common cause of foot compartment syndrome is calcaneal fracture. And remember, if you have a patient with athlete which is doing a lot of sports, which you have to ask him if he has any calcaneal fracture before or not, because sometimes it's a subacute compartment syndrome which was very unnoticed, and the patient end by contracture and flexion of his short muscles. And if you need to do an FHL transfer in this man, you need to understand that his intrinsic are short and he cannot use them, so it's not optional for him to lose the FHL. It's a bit clinical dilemma, but remember, if you're going to do an FHL transfer for a chronic Achilles rupture, you have to ask the patient if he has a calcaneal fracture before or not, especially if he's athlete. Because if he has a calcaneal fracture, there will be some subacute compartment which end by some contraction in the intrinsics. So without intrinsics, you cannot move, as we agreed, that the long tendons, flexor and extensor, move the IB joints, but the MTB moves with intrinsics. And if you lose your intrinsics because of a chronic compartment syndrome from a calcaneal fracture before, you cannot lose your long as well. That's why you cannot do an FHL transfer for a chronic Achilles in this patient. If we're doing an ankle arthroscopy, so this is our portals. We have anterior and posterior ankle arthroscopy. Remember that you need to mark them. This is one of my patients. So this is the tib ant, and this is where the extensor digitorum and the peroneus tertius is, and this is my SBN. As you see, if you pull on the fourth toe, you will see the SBN very clear here. So your portals will be anteromedial, just medial to the tib ant, between the tib ant and the medial malleolus. Your lateral portal will be between the peroneus tertius and this SBN, and definitely for both portals, you just inside the skin. And after incision of the skin, you go with a clip just to be sure that you're not attacking any of the tendons or the nerves, and then you go in. Remember, when you're scoping the ankle anteriorly, you are not going into the ankle. You're actually going into the anterior compartment. So the direction of your scope and instrument is not like that, is like that. Posteriorly, very simple. The patient is prone or lazy lateral. Then you basically put some instrument here to have the axis of the foot. From the axis of the foot, you put this axis or the instrument at the same plane over the tip of the lateral malleolus, and then this will be the level of your portals on both sides of the Achilles, medial and lateral. So an instrument here over the heel to know the axis of the heel, move it proximally over at the tip of the lateral malleolus, then mark on both sides of the Achilles. This will be your medial and lateral portals. I don't think we'll have a time for gait. فنخلي الجيت المرة الجاية ولا الشباب لسه صاحيين؟
أنا متهيألي الأفضل نخليها المرة الجاية.
صح؟
متهيألي
هبط. طيب اي حد عنده اي اسئله، حاجه مش واضحه، حاجه مش بتاع، حاجه وحشه، حاجه كويسه، اي حاجه، اي كومنتس. خلاص يا ابو حميد، ان شاء الله فور نيكست تايم ما تقلقش. آه طب اي كومنت؟ طب do you feel it reasonable? Do you feel it long? Do you feel it short? Shall it be completely in Arabic? Shall it be completely in English? Any comments? Anyway, you will receive a feedback after the session. We already should have received the feedback from mid-all. Put all what you want in the feedback. This is how I get the insight of it. Tell me what's wrong, what's good, what's bad, what do you feel okay, what do you feel wrong. A lot of talking, a lot of brainstorming. So if there is any mistake, send to me and I can correct it. Um, if you put yourself in my shoes, you will have a lot of stress. Just to confirm, the midfoot, CCG, and TNG moves. Yeah, definitely. If they don't move, you will not walk. So the moves basically how your arch form is. Arch form is because the head of the tail, the navicular goes into plantar flexion over the head of the talus. And the other way in the calcaneal cuboid. So they definitely move. That's why they are joints. And this is how they are oriented. Exam oriented, Abu Hamid, this lecture couldn't be anything except that, because this is the base. If you don't have the base, there is no way to answer any question. Distal to each other, level distal and proximal doesn't make a big difference. So a telonavicular is more distal to the calcaneal cuboid, but it's not more. It's distal to the calcaneal cuboid. But the point is the plane. If the foot is flat, they are in the same plane. If the foot is arched, the telonavicular is in a plane, is a superior plane than the calcaneal cuboid. So they are locked. So the point is not if they are distant to each other. Yes, they are distant to each other. And as I told you, telonavicular is distant to the calcaneal cuboid. But the point is how the plane. If they are in the same plane, the foot is supple. If they are in different plane, the foot is rigid. And you need the supple to accommodate the ground, and you need it to be rigid to push off and have a rigid lever. About the exam orientation, this lecture, without this lecture and the gate, is so difficult for you to understand how we're going. Exam orientation will be from the not next lecture, the lecture after, because it's about the pathology. But you will have this question in the exam, and if you both part A and part B, but if you don't have this understanding of the basic knowledge, anatomy, biomechanics, and gate, you will not be able to answer them. And if you digest this lecture nicely, you understand every point of it. You go and see the video, do whatever you want. Video will be in the middle if you want to go back to it and understand it very well. All the lectures, the coming lectures, will be very easy. This is what I will speak about in Flatfoot, in Cavus, in this rank. As you see, all the lecture is clinically directed. But without this lecture, no way. It cannot be exam oriented in a sense that they will ask you about. No. If you understand the bits of clinical anatomy, this will make you make you efficient to answer any anatomical question, any biomechanical question, and it makes your understanding of the pathology very easy. Without understanding the physiology and anatomy, is so difficult to understand the pathology. That's why the foot and ankle pathology is a dark side. It's dark side because most of the people are not on top of the basics. If you get these basics nicely, digested nicely, it's so difficult to come with everything in the lecture. Go back to it. Anything unclear, anything you feel wrong, sometimes some of the information I give you, because it's all just interchanging between varus, valgus, inversion, eversion. If I miss say some words, just be back to me, and I will explain it to you. Feedback will come to you. Very good evening for every one of you, and a good night. And see you in the next session next Friday. Okay?
Thank you, Mr. Hashim.